Hello. I took I took longer time. Okay, we can start. We can see the screen. Or no? Hello, doctor. Huh? Oh, did I? Extra. We can start. We can start. Huh? Uh, Good. Okay. Gastric cancer. Gastric cancer. Pathology report shows signet ring cell carcinoma. Uh, Positive lymph nodes are one and spleen removed. Discuss the pathology report. Okay, this is the cancer of the stomach. This is the cancer of the stomach, and not completely removed. So, this patient may require further resection and chemotherapy, and this may come back again. And gets the plan for the patient post. What is the plan for post splenectomy? Uh, Give vaccine for the patient after 2 weeks against polysaccharide encapsulated organism. Give vaccine for the patient after 2 weeks against the polysaccharide encapsulated organism like Neisseria meningitidis, Haemophilus influenza, and Staphylococcus pneumoniae, and prophylactic antibiotic to protect against prophylactic antibiotic to protect against post-splenectomy overwhelming infection. Post-splenectomy overwhelming infection and influenza vaccine yearly. This is a new one. Influenza vaccine yearly. Okay, yearly. Mention 4 important risk factors for gastric cancer: H. pylori infection, chronic use of where is chronic use of NSAIDs. Okay, 4 important risk for gastric cancer: H. pylori infection, then chronic atrophic gastritis, family history of gastric cancer, FAP, adenocarcinoma, polyp more than 2 centimeter, and previous gastric surgery. This is more than 4. Okay. H. pylori infection, family history of gastric cancer, previous history of gastric surgery, adenomatous, familial adenomatous polyp, and adenomatous polyp size more than 2 centimeter, and chronic atrophic gastritis. How does gastric cancer develop? Normal mucosa will change to due to chronic gastritis, intestinal metaplasia to dysplasia, in situ, intramucosal carcinoma, intramucosal carcinoma, then invasive gastric carcinoma, intramucosal carcinoma, invasive gastric carcinoma. Chronic gastritis, intestinal metaplasia to dysplasia, dysplasia to in base intramucosal carcinoma and invasive carcinoma. Um, mm, what is the commonest histological type is adenocarcinoma, 95%, WHO classification, Doran classification, Bowman classification, tubular adenocarcinoma, papillary adenocarcinoma, mucinous adenocarcinoma, mixed carcinoma, and poorly cohesive carcinoma. Tubular adenocarcinoma, tubular carcinoma, papillary carcinoma, and mucinous carcinoma. TPM is my hospital exam center number name. Tubular adenocarcinoma, tubular adenocarcinoma, papillary adenocarcinoma, and mucinous adenocarcinoma, mixed carcinoma, and poorly cohesive carcinoma. 10 days later, develop diffuse painful swelling on the left arm. It is DVT in the left axillary vein. What are the predisposing factor of this patient? Hypercoagulability due to malignancy and venous stasis from the Varco's lymph node. How can you define paraneoplastic syndrome? Okay. Do you know any paraneoplastic syndrome associated with gastric carcinoma, xeroderma pigment? No. Acanthosis nigricans, and dermatomyositis. Acanthosis nigricans, dermatomyositis. Acanthosis nigricans, dermatomyositis. Acanthosis nigricans, dermatomyositis. Acanthosis nigricans, dermatomyositis. Acanthosis nigricans and dermatomyositis. Acanthosis nigricans and dermatomyositis. Okay. Then how does gastric carcinoma? Where does in the left gastric lymph node? What are other routes of spread? Hematogenous, transcelomic, and direct invasion. Hematogenous gastric carcinoma. Hematogenous, transcelomic, and direct invasion. 6 months later, the patient presented with abdominal distension, positive shifting dullness. It is a metastasis to liver and malignant ascites. Malignant ascites. What we can do? Ascitic tap liver biopsy, and FNC from the supraclavicular lymph node and tumor marker CA 74, 7244 recurrence, 7244 Again, ascitic tap and cytology, liver biopsy, FNC from the left supraclavicular lymph node tumor marker CA 72-4. What would be your plan if the recurrence and advanced age palliative treatment, including debulking, feeding jejunostomy, palliative chemoradiotherapy, pain relief by opioid, and palliation of the ascites by repeated tapping. Palliation of ascites by repeated tapping. Palliation of ascites by repeated tapping. Mm, hmm. Then, how does SITs develop due to high interstitial no impaired liver function, decreased synthesis of the albumin, hypoalbuminemia. Impaired liver function causes decreased synthesis of the albumin, hypoalbuminemia, and low plasma oncotic pressure and high interstitial pressure. Portal hydrostatic pressure. Portal hydrostatic low plasma oncotic pressure and in this portal hydrostatic pressure causes ascites. How to treat malignant ascites? Malignant, uh, treat underlying cause of the cancer. First, treat the underlying cancer with chemotherapy and surgery. Treat underlying cancer with chemotherapy or radiotherapy. Then paracentesis and cell-free concentrated ascitic reinfusion therapy or peritoneal venous shunt. Periperitoneal venous shunt. Again, um, treating underlying treating underlying cancer with chemotherapy. Treating underlying cancer with chemotherapy, paracentesis, peritoneal venous shunt, and cell-free ascitic reinfusion therapy. Cell-free ascitic reinfusion therapy. Cell-free ascitic reinfusion therapy. What are the procedure-specific complication can happen in the gastrectomy? The early complication: anastomotic leak, pancreatitis, cholecystitis, hemorrhage, and infection. And late complication: dumping syndrome, vitamin B12 deficiency, metabolic bone disease, I don't know, and recurrence of the malignancy. Dumping syndrome, vitamin B12, dumping syndrome, vitamin B12 deficiency, and recurrence of the malignancy. Dumping syndrome, loss of reservoir function of the stomach following gastrectomy result in the rapid transit of the highly osmotically active substance into the duodenum. Following meals may cause dumping syndrome. Early dumping in 30 to 60 minutes following meal. Rapid transit of the hyperosmolar gastric content into the small intestine causes fluid shift from the intravascular compartment into the gastric lumen and small bowel. Distension, colic abdominal pain, diarrhea, and vasomotor symptoms such as tachycardia, postural hypertension, and late dumping 1 to 3 hours following meals. A rapid transit of the carbohydrate into the small bowel result in sudden absorption of uh, high level of glucose and compensatory hyperinsulinemia result in subsequent hypoglycemia. What is the name of familial and type of gastric cancer? Hereditary diffuse gastric cancer. Hereditary diffuse gastric cancer syndrome. 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 Gene mutation CDH1 and autosomal dominant. Gene mutation CDH1 and autosomal dominant. If a mutated CDH1 genotype of the cancer may be associated with colon cancer, rectum cancer, prostate cancer. CDHN, colon cancer, rectum cancer, prostate cancer, and hereditary diffuse gastric cancer syndrome. Hereditary diffuse gastric cancer syndrome, colon cancer, rectum cancer, and prostate cancer, lobular breast cancer. Sprinkler criteria for okay, this one is bad one. I don't. Okay. What is the age of the screening of CDH1 gene? What is the age of screening of CDH1 gene? 16 to 18 is adolescent. Legal age of the consent 16 to 18 years. 16 to 18 years of age. Legal age of adolescence 16 to 18 years. 16 to 18 years of the age. 16 to 18 years of the age, 16 to 18 years of the age, 16 to 18 years of the age, legal age of consent. What is the age of prophylactic surgery? Between 20 to 30 years. Okay. Screening CDH1 is 16 to 18 and prophylactic surgery 20 to 30 years. Other than adenocarcinoma, what other types of gastric cancer? Gastrointestinal stromal tumor, carcinoid, neuroendocrine tumor like carcinoid, and then squamous cell carcinoma, melanoma, yeast, melanoma, carcinoid, hereditary diffuse gastric carcinoma, and squamous cell carcinoma. What is CDH1 gene and function? CDH1 is a tumor suppressor gene, encodes a protein called cadherin. Okay, mutation and loss of function. Okay, it is a tumor suppressor gene. Okay, types of mutation. Uh, types of types. Hmm, types of hmm, types of mutation in CDH1, autosomal dominant, hereditary diffuse gastric carcinoma is an autosomal dominant. However, both copies of the CDH1 must be inactivated causes of gallstone and causes following critical gastrectomy. Uh, causes of gallstone, causes of gallstone and cholecystitis following radical gastrectomy. Okay, loss of vagal innervation to the gallbladder, loss of vagal innervation to the gallbladder, and bile stasis and gallstone formation. And another mechanism, loss of cholecystokinin released from the duodenum after bypass of the duodenum endocrine Y reconstruction. Gallbladder contraction increase the bile salt uh, concentration increase. Okay. Causes of post-gastrectomy acute pancreatitis. Acute pancreatitis. Okay, direct iatrogenic injury during surgery, microcirculation compromise, and duodenal hyperplasia, duodenal hyper pressure, and postoperative spasm of the major papilla. Duodenal hyperplasia and postoperative spasm of the major papilla. Direct iatrogenic injury during gastrectomy, and microcirculation compromise, and duodenal hyperpressure, and postoperative spasm of the major papilla. Causes of post-gastrectomy anemia due to vitamin B12 deficiency and iron deficiency anemia. Causes of iron deficiency: iron requires acidic gastric. mm, Causes of iron deficiency: iron require acidic gastric meal for absorption, which is lost. There is lack of absorption of iron in post gastrectomy reconstruction bypassing the duodenum, such as Roxanne Y and Billroth procedure, as iron get absorbed in the duodenum. Co- hmm, hmm. Causes of post-gastrectomy metabolic bone disease, osteoporosis and osteomalacia caused by reduction of the food intake and absorption and steatorrhea. Osteoporosis and postoperative post-gastrectomy metabolic bone disease, osteoporosis and osteomalacia caused by reduction of the food intake and absorption and steatorrhea. Steatorrhea interferes with absorption of calcium and vitamin D from the gut. Steatorrhea is caused by exocrine pancreatic insufficiency. Exocrine pancreatic insufficiency due to post gastrectomy pancreatitis. Hmm. We'll finish two more up to 20 we can finish. Now it is 7:20. No. Hmm. I didn't cook. No, no, now how can I didn't cook anything. I didn't cook. No, we can finish to more station. Two or three. No, let's see. Remaining see polytrauma, then this thing it will be easy. Gallbladder, oh no, polytrauma, then gallbladder, then tissue cancer, nasopharyngeal carcinoma, a sickle cell disease, osteomyelitis, man 1, man 2, TB, GIST, esophageal carcinoma, rectal carcinoma, breast cancer, radiotherapy, malignant melanoma, acute pancreatitis. This should be last, or actinomycosis. This one totally brand new. And hand squamous cell carcinoma. These two maybe. Ha ha ha. Anatomy, color. Hmm? You have food. You have food. Asthma cooking, mama cooking. Okay, let's finish. Prostate cancer. Prostate cancer. Hmm. What is the most probable diagnosis? DRE reveal enlarged palm, rounded prostate with a preserved median sulcus. Preserved median sulcus. So, what is this? This is benign prostatic hyperplasia. And why it is prostate cancer? Because it was hard nodular fixed with the rectal wall and obliteration of the medial sulcus. Three investigation in the outpatient clinic: PSA, mid-stream urine analysis, and urea electrolyte and creatinine. PSA mid-stream urine analysis. Urea electrolyte and creatinine. Most important investigation to confirm the malignancy, transrectal ultrasound guided biopsy. Transrectal ultrasound guided biopsy. How it is done? Transrectal ultrasound guided biopsy, mid-low parasagittal plane. Mid-low parasagittal plane will take a biopsy from the apex, from the mid gland, and from the base, and bilaterally, and should take more than 10 biopsies. Why there is need for? Because prostate cancer is a can be focal, so it is important to take samples from the different sites. Biopsy shows high-grade prostatic neoplastic tissue admixed with rectal glandular tissue. How can prostatic cancer can be diffused? Okay, by using immunohistochemistry and immunohistochemical marker in rectal cell, carcinomembranous antigen will be positive, and in PSA, uh, and PSA is negative. Okay, opposite. Mhm. We can say opposite also. And in rectal cell, carcinomembranous antigen will be positive and PSA will be negative. And if it is rectal, if it is prostatic tissue, PSA will be high and PA will be negative. Okay. What are the gene mutation involved in the pathogenesis of the prostate cancer? Yes, this is BRCA1, BRCA2, and check ATM. BRCA1, BRCA2, ATM, and check 2, CHEK2. Okay, check 2. Patient underwent TARP for the prostate cancer 6 months ago. Last PSA was raised because of a recurrence in high PSA after prostatectomy. The recurrence should be considered. Fall in the prostate PSA below the detective level should come in the 4 to 6 months if known it first time. High PSA after prostatectomy recurrence should be considered. PSA is not very okay. PSA is organ specific, not cancer specific. Serum PSA elevates in both cancer and BPH, but in CA it elevates more than the BPH, and other factors such as prostatitis, infection, hyperplasia, instrumentation, and to the prostate and ejaculation also increase the PSA. What is the name? What is the name of the grading system? This is the Gleason score. Two biopsies are taken from prostate cancer. Two biopsies are taken from the prostate cancer. Then the pathologist allocate them in the number from 1 to 5 for the most common histological pattern. The pathologist allocate them from 1 to 6, 1 to 6, 1 to 5 for the most common histological pattern in the specimen, and then does the same for the second most common pattern. The sum of the number will be the Gleason score. 0 to 2 is the score, 0 is the well differentiated, and 10 is distal metastasis. Name the staging system of the prostate cancer, TNM. Patient with prostate cancer developed back pain, and CT showed increased density in the lumbar spine. What is the diagnosis? Lumbar spine metastasis. Lumbar spine metastasis. Mention one laboratory test to be excluded and bone metastasis, alkaline phosphatase. Mention one laboratory test to exclude bone metastasis, that is alkaline phosphatase. Phosphatase. What is the type of this metastasis? Sclerotic, due to increased bone deposition. Alkaline phosphatase. What is the type of this metastasis? This is sclerotic due to increased bone deposition due to increased osteoblastic activity. Due to increased bone deposition due to increased osteoblastic activity. Post-TURP patient develop fever, confusion, dysuria, dusty urine because of UTI. Investigation with the blood, investigation, urea, CBC. inflammatory cytokines, ESR, and urine analysis, and also culture and sensitivity of the urine. Other investigation will do blood for culture and sensitivity, blood CBC for blood CBC is CRP, ESR. This is your third time. 5 minutes. No. Mm, what is the number of the colonies analysis for the specimen? More than 1,000, more than 1,000. Which of the blood component raise neutrophil count raise? What is the primary stimulus of the prostate growth? Androgen. Because androgen, the growth and survival of the prostate cancers depends on the androgen. So, if the androgen deprivation, it reduces the rate and growth of the cancer. That's why in the past it was used. Now also it is used. Okay. After, apart from the surgery, TURP, and medical deprivation, do we still have orchidectomy to treat prostate cancer? Yes, we have medical orchidectomy. Pathological fracture. Female patient cycling, he kept her foot and break down. What is the type of fracture? Pathological fracture. It is a fracture of a bone which occurs without adequate trauma, which cause in pre-existing pathological bone lesion. What are the causes of pathological fracture? Neoplastic, non-neoplastic. Neoplastic is a primary, metastatic, primary, like multiple myeloma and metastatic. Neoplastic, primary and metastatic. Primary, multiple myeloma, metastatic. Okay, non-neoplastic, osteoporosis, osteomyelitis, osteomalacia, osteogenesis imperfecta, Paget's disease, bone cyst, radiotherapy. Osteoporosis, osteomyelitis, osteomalacia, osteogenesis imperfecta, Paget's disease, bone cyst, radiotherapy. Breast, prostate, lung, thyroid, and kidney. What is the name of the brain tumor causing sclerotic metastasis, medulloblastoma? Brain tumor causes sclerotic metastasis, medulloblastoma. Fracture was treated with internal fixation. How to check for malignancy? Hmm? How to check for malignancy? Bone biopsy. How to check for malignancy? Bone biopsy. Pathological result shows typical bland appearance, follicular cell. What are the probable location of the primary site? It is thyroid gland. Why thyroid gland? Okay, FNC was done, but why it is not confirmed? Because in the follicular thyroid neoplasm, malignancy is because of follicular thyroid neoplasm, malignancy is determined by the capsular and vascular invasion, which need histology rather than the cytology. What are the other sides of the ectopic thyroid tissue in the ovary and the testicular teratoma? Ovary and testicular teratoma. How, which investigation can be done to confirm the thyroid metastasis to radioactive iodine scan? Which type of thyroid cancer that will show no response to be medullary thyroid cancer, as it is originated from parafollicular C cell. It is not from the follicular. It is not from the. It is not from the follicular origin. Tumor marker for medullary thyroid cancer, calcitonin. Tumor marker for thyroid cancer. Tumor marker for medullary thyroid cancer, calcitonin. Calcitonin. The patient needed blood transfusion during surgery. What need to be the transfusion? ABO blood grouping and RH typing and cross matching. ABO grouping, RH typing, and cross matching. If the patient blood group is known, would you still need to cross match? Yes, to determine The recipient has preformed antibody against the donor's RBC. Complication of the incompatible acute hemolytic reaction, delayed hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, and transfusion related lung injury. Acute hemolytic transfusion reaction, delayed hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, transfusion related acute lung injury. Defined hemolysis, rupture of the RBC and release of the content in the circulating blood is called hemolysis. Polytrauma. This is the time. Hmm. Hmm. Okay, then we can make some noodles. Hmm. Yes, then we'll go for some. Huh? Then. Mm-hmm. Can't you know? The session going on 5 hours 26 minutes. You have seen? Hmm. Then then you can cut the call. Uh, will reduce. Hmm.